First, I would like to thank you for the invitation of Isags for this presentation. Thank you all for being here. Can I have my slides, please? Well, today I will discuss the renunciation of fiscal resources in Australia, Canada, and the US. And as a background, we will discuss the relationship between the public and the private. And by the end of the debate, we will present some points around the issue around the universal health system discussion and universal health coverage. This is the outline of our presentation. We'll have a theoretical discussion about the issue very shortly. Then we will talk about the research program around the problem, and this can be developed by Isags themselves. We will highlight, based on international literature, what does it mean, the subsidies, the resignation or resignment of fiscal resources. Then we will discuss the experiences of those countries that have different models. And finally, we will talk about some challenges for UNASUR countries.
Uma primeira abordagem que
I would like to start by saying that the presence of subsidies would lead to an increase of the equilibrium level in the health plan market, be it by the state, because they would be able to operate with a price over the market price because of the subsidies. This discussion is done or is carried out by the economists who are a believer in the neoclassical theory. The reference here is Pauli, a North American author, and this article was from 1986. On the other hand, another approach that somehow is what we follow is the one that indicates that the presence of those subsidies, on the other hand, favor the profitability conditions of the health insurance plans. The idea behind it is that the health sector, if it is organized in a capitalistic way, due to its characteristics of costs and prices always growing, will present profitability problems once this happens. How? Well, since this health sector is very important from the social and political point of view, this will place the state facing the dilemma of applying subsidies in a private activity, which is important socially, but has profitability problems, or increase the intervention models based on social security, or in other words, the universal health system. This is a second approach that we notice in the literature. Anyway, since this market in the US case or in the Brazilian case, which are the two markets I know better, since this market is being centered and going international, another discussion that we also notice in the literature is that from the supply point of view, this subsidy would make very little sense because the market has become self-sufficient. This is another point of view of the problem in terms of expenditure of taxes. The market is self-sufficient. Is it possible then that the state or the government applies resources in this area? Yet another possible approach to analyze this object is the one according to which the presence of subsidies, if we imagine that the employers should pay for the cost of replacing the workforce, these subsidies would be an element to help the employers to socialize the cost of reproducing the working force. So, considering that employers, the capital, if you wish, should pay for the costs related to the reproduction of their own workforce, labor force. So the subsidy can be understood as an idea of the state socializing the cost of this workforce with the capital. This is, of course, a Marxist approach. From an operational point of view, this idea of tax expenditure is very important to us because this is a public expenditure, an indirect expenditure, which is allocated to the private sector. That is, the state does not recover these resources on behalf of certain economic activity or the consumption of certain services, in our case, the health area. So if this concept of tax expenditure is a consensus, indirect costs are public costs, and these have implications in the accounting of the national accounts when we analyze the composition between public and private in the health sector. For instance, if in the case of Brazil, private stands for 56 and 44. If you consider that subsidy is a public expenditure, these numbers will shift. The composition will change. And we know that this discussion has political and ideological implications that are not simple at all. And the other element which is dear to this debate is the discussion about equity or inequity of this kind of subsidies in the Brazilian case. And probably in the Argentinian case, as we heard yesterday by Dr. Mariano, and the US, as we will see, this subsidy is allocated for the upper income classes. And you can understand that this allocation is not fair, is not balanced, especially in societies that have unequal incomes and well-being. So very soon, very briefly, I tried to show you some points of view that we find in the literature about these problems. Next. Is the previous one. based on the presentations that were done yesterday, Mr. Mariano made it clear that we should improve our capacity of producing good quality about these subsidies. In the Brazilian case, we were able to advance in this area. In Australia and Canada and the US, this is also quite advanced. Now we have to measure. Is there subsidy? Yes. How much? So the measurement seems to me necessary in this comparison between public and private in the health sector. The second line of research is to discuss the distribution of the federal government expenditure in health, in the health area in general, because if you understand that the indirect cost is public, and if you understand that this public expenditure is allocated to those segments of the population of higher income, it is uneven. So subsidies are increasing the imbalance of society, because if you divide by the population per capita, a certain part of the population, the richer, would be receiving something more. Of course, this has to be adjusted to the use of the public health systems. But we can imagine, theoretically, that the distribution is uneven because of that. The third line of research is the expenditure of families with health. One of the arguments used to apply these subsidies is that the public sector is overloaded with a low quality of services, so that segments that would be willing to go to the market would receive a subsidy from the government. But this also has to be seen in a cautious way, especially if those segments also use the public health systems. That is, if there's no penalty, like in Germany. In Germany, if you go to the market, this is your decision, and it has its own cost. If you decide to go back to the public sector later on, it has a cost. So I think this is also an important point to discuss, how much families spend in drugs, physicians, health plans, hospitals, so that we have a better idea of the inequity of this system as a whole, and not only the relationship between public and private, but in the whole system. As mentioned before, the subsidy encourages the market of health plans, and I would say that at first this market depends on the subsidies to reproduce, economically speaking. It's not only a fiscal step down, you know. In the Brazilian case, I could affirm that, but I would not like to make it universal. Because if we analyze this in a capitalistic way, it will present inequality problems and very high prices. Because since it's an important social point, you know, the state has to intervene, subsidizing the prices, or otherwise it has to intervene. So there's an impact about the market dynamics that is not of secondary importance, you know. I am saying it's not only on the dynamics that it has an impact, but also on the reproduction of this market in the long range as a capitalist sector. Another important element is that this fiscal exemption has an impact on the revenues of the market. Who pays a health plan in a scheme or the state subsidize the market? Are the workers' families, the employers, and the state through this exemption. If we could, you know, decompose the revenue of these markets, it is composed by the family's resources, employers' resources, and the state through the exemption, fiscal exemption. So the state also participates through the subsidies in an indirect way of the composition of the revenues of the market. And finally, especially if the subsidy represents an important amount vis-à-vis the direct public expenditure, for instance, in the Brazilian case, the last data we have is that the subsidies of the individual and companies, and also those for the pharmaceutical industry and the charity hospitals, reaches 23 billion reais, which is almost 30% of the federal public expenditure. So it's quite a lot of money. If it is significant, as it is, in a situation of fiscal restriction, this is an amount that the government cannot control, theoretically, because this expenditure would depend on the expenditure of how much families and employers spend in the health area. These are the basis of calculation for the fiscal exemption from the government. So they have to regulate, evaluate the quality and the efficiency of this expenditure. And for that, I would conclude by saying that we have to measure, and that's not simple. It takes us in Brazil like 8 years to be able to get those data. Please.
Well, now changing the subject a little bit, but not too much, the exemption as a public policy. Thank you. So this type of policy you can identify as a benefit once the person is reduced in the payment of income tax, and that seems to me as a direct relation. Another argument to justify the presence of the subsidy is the reduction of taxes for taxpayers that would face catastrophic health expenditures, and I will not go into details of that justification. We can talk about it later on. Another common argument in the literature also mentioned here is the attempt to reduce costs and also the waiting lines in the public sector. So you subsidize certain segments of the population so that they can go to the private sector in the expectation that it would reduce the demand of the public sector services. Another argument that is very common in the literature would be the sponsorship of this market. With a subsidy, you're sponsoring the consumption. And you could also understand this exemption as a sort of incentive for you to shape the reglementation of such market. Without tiring you with the Brazilian experience, but that's the one that I know the most, try to imagine if such subsidies could help our regulatory agency to define the limit for the pricing of the private American insurances, such as happens with the drug market in Brazil. So the same regulation that is focused to the pharmaceuticals in Brazil has as its counterpart in the law the pricing control. In a health sector that is more flexible. But what we are interested in, and it's just an example to illustrate, is that this benefit could also be seen or construed as an incentive that might help the state to redesign the medical insurances market once this subsidy is important for its dynamics. Next slide, please. And to a certain extent, despite although I'm presenting to you these theories and the research program that could also provide support to this type of investigation, the attempt at comparing these countries is it is exploratory in a way, but at the same time it is some sort of a first approach, so that we do not deepen the comparisons between the experiences that we are about to analyze. More specifically, we want to understand the rationale of this tax expenditure in these systems. So in certain cases, the government loans a certain rationale to these subsidies in certain documents, and in different realities, sometimes it doesn't do the same.
Como já dissemos fartamente,
As we've said, the literature shows that some countries have these incentives to some taxpayers due to reduction of taxes for the consumption of goods and health assistance. Using a space as a welfare state, like we have in Europe, this institutional arrangement seems to reinforce the private model. Once the market depends to a certain extent on these subsidies, in line with the United States case. Next, please. We analyzed the institutional experiences of Australia, Canada, and the United States that have the presence of a medical insurance markets. Countries with small markets, the presence of the taxed expenditure is residual or not localized or inexistent. That's the example of Germany, the UK, or France. Health systems organized based on the safety and social security models. To a certain extent, there is an embedded idea that the presence or the existence of subsidies is directly related to the presence of the market functioning when it comes to medical insurances or the private sector, generally speaking. Next slide, please. Such experiences might teach us important lessons in regard to the way of dealing with subsidies focused on families and employers in South America. And I mentioned the cases of Argentina and Brazil, but it might be even that in the afternoon today, since the Colombian case has a different profile, other countries might say something about it. I'm not aware of their experiences, at least from this point of view in South America. And I was actually surprised because I looked it up in the literature and I didn't know, I wasn't aware of the existence of this subsidy in the Argentinian case. And I have to admit that. And I try to keep up with the literature in this field, but still. Please, next slide. This table goes up to 2008, so it's a little bit outdated, but just so we have an idea of the coverage of the medical insurance market in regard to the population. Australia in 2008, 50% of the population was covered by the market. The resident case remains, but this 26.1 will be including the dental plans also. In Canada, it is worth to mention that since there, in fact, the private sector is just supplementary, we're talking about the coverage in the supplementary market sector. Up to 2008, it would have increased, but this data is from OECD from 2010. In the United States, I don't know exactly why it decreased, maybe due to the aging of the population, and then a measurement of OECD does not consider the sectors that were included in a Medicare in the medical insurance calculations, but we know that there are some private schemes currently to focus on the elderly population. In the case of North America, that Professor Marmer will be able to speak better later on. So this table is just to illustrate like the magnitude of the markets in the countries that we are about to analyze. In Brazil is included here just because, you know, we are here. The Australian case, it offers universal coverage through Medicare. They also have this name, Medicare.
Em 1999,
In 1999, the Australian government introduced this program, private health insurance rebate incentive, to promote reductions in the purchase of medical insurances of about 30%. In summary, to make it clear, for each dollar unit that the individual would pay to the medical insurance, the government would give back 30 cents of a dollar. All Australians that were eligible to Medicare would then also be eligible to the discount. If the employer paid a premium instead of the employee, the discount would also be applied, considering that the financing of this market is generally done by both the employer and the employees. However, this discount policy of 30%, according to literature, had little impact in the increase of medical insurance coverage. Well, so we could then highlight that this policy in Australia, in a deliberate way, in other words, it wasn't a policy that didn't emerge empirically, but it had as its presumption and objective in theory to reduce the demand over public services when it comes to health. I'm not going to go into details about this policy. I'm just saying that the government had this initiative, implemented a policy, and this policy was not very successful. So what did they do next? Next slide, please. In 2000, the government introduced the coverage policy that would stimulate youngsters to purchase medical insurances, aiming to keep their affiliation throughout their life cycle due to the need of equilibrium of the portfolio of the medical insurance companies at the moment. So the youngsters, in theory, do not get sick so frequently. So it would work the following way. If the youngster did not purchase anything up to the age of 30, they would have to pay 2% extra in the premium for each year, subsequent year that they remained with the insurance, so stimulating then the youngster to join the medical insurance market earlier in order to create a more balanced pool and consequently increase the coverage of the private plans. Now, explaining the policy a little bit more, if the youngster bought a hospital coverage at the age of 40, this person would pay 40% more than someone that had done it at the age of 30. After 10 years, this additional money would be removed, this additional charge would be removed. And as a result of that policy, 4 years after its beginning, the size of the market went from 15 to 45% of the population. So from the point of view of the Australian government, this policy that helped the introduction of youngsters in the market favored the increase of medical insurances purchases. After that, the government had to deal with the elders due to the increase of the premium in accordance to the morbidity profile of this populational sector. So the Australian government introduced new rebates, new discounts related to the elderly. 30% for those younger than 65, 35% for those between 65 and 69, and 40% for those 70 plus. And you know that obviously this populational group has a sickness burden, so to speak, that is bigger, which would increase the costs. So this policy meets the preliminary policy defined by the Australian government. The health plans are subsidized in Australia so that people can avoid the waiting lines in the public sector, those who can afford that, and that amount was equivalent to 7% of the total of the public budget for the health sector. This data is from 2010, even though it refers to 2008. Next slide.
No caso,
In a Canadian case, as I previously said, all Canadian citizens receive public coverage through Medicare. However, two-thirds, according to data from OECD, two-thirds of Canadians, and this data is from 2010, I don't know if there has been some change since then, they have a supplementary health insurance. However, it is not allowed to have a private coverage of some services covered by the Medicare, which is an enormous difference between that market and our market. So the market in Brazil finances services provided by the private sector that are equally offered by SUS, which is our universal system, that is not allowed in the Canadian case. So for those services that are not included in Medicare, people can purchase them. They can pay a health insurance to have access to those services that are offered in the complementary model or a complementary supplementary system. I apologize. Based on the OECD classification, and a private supplementary insurance is provided by the employer. That is important to be said, encompassing dental care, home care, medications, and long-term care. Next slide, please.
foi criado
They created a tax credit specifically over medical expenses that works as a subsidy for the expenses with health insurances and taxes of families directly. So the legislation has a long list that the federal authorities see as a tax exemption for taxpayers, encompassing a set of items: hospitals, prostheses, dentures, home care, etc. Premiums of the plans also. So the state subsidizes the families that want to have a supplementary insurance. According to literature, the individuals in different provinces receive subsidies that are substantially different in comparison to its costs due to the bigger or smaller presence of the supplementary sector. So the ability of offer of Medicare, even though that is not written here, and even though there's no objective data about that, Professor Mummer, that is said, let's say, in literature, but it seems to me like it's necessary to have more empirical evidence. That way, therefore, what I'm going to say about Canada is also valid for the Australian case when it comes to the high cost that they have. 7% of the budget is not little money at all. And to regulate and limit increase of the subsidies to the private sector plans, the government intends to strengthen Medicare, widening its coverage and diminishing the waiting time of certain services. Next slide, please.
minha visão.
The way I see it, if we want to advance in the analysis of the public and private sector relationship, and I say we in South America, not because this has been my experience, but it seems to me that observing the North American case with the productive strengths there, if you understand what I'm saying, considering that they're more developed there when it comes to the dynamics of the market, it might be there that we can learn the best lessons, even though the lessons might be how not to think about the North American case. In other words, how to, he's repeating in Portuguese, not to think about it. I mentioned Professor Jacob Ocke, who is part of the Professor Mummer's team. And Professor Ocke, he was one of the creators of Obamacare. We'll speak about it later, at least as far as I know, in the sense of the creation of the state health care that was defeated in the National Congress in North America. And in his doctorate thesis, he has an insight, an observation that is quite interesting. He says that there is a certain wrong impression that the health policy in the United States is focused on the poorest. When it comes, in this case, that would be the Medicaid. He might be also referring to elderlies, but he's mentioning the poorest ones. He says the following: the tax incentives related to employment are, to him, what distinguishes the particular case of the United States. And I, at least in my opinion, in the Brazilian case, I could say the same. The private insurance is the main access to health coverage because the public sector somehow covers the poor and the elderly, even though a lot of people are not eligible for the programs, and that's why Obamacare came about. But sometimes they have access through Medicaid and Medicare. So the estimate of the expenses in 2008 was of 800 billion. And tax exemption, Professor Moore, according to a Foreman article in 2008, I forgot the name of the journal, but I'll think about it in a minute, was of about 250 billion. I was absolutely flabbergasted when I saw that, and I couldn't verify it in the documents of the American Treasury. But if that is true, that means that the government would be financing almost 33% of the total expenditures with medical insurances in the year mentioned. In other words, Obamacare wants to expand that to those segments that were outside, so to speak, of the system. But even before Obamacare, the presence of the subsidy in the North American case was already extreme, and therefore it reinforces our thesis of the dependence of this market so that we can reproduce it economically speaking. In other words, in a structural dependence between the standard of the public financing and its dynamic of capitalist accumulation, if you allow me to speak in Marxist terms. So the company plans are the most important share market. One of the main causes of the growth of the private coverage is due to guaranteeing to the employer the possibility of exemptions in tax due to their expenditures with healthcare plans for their employees. So the same thing that happened in the Australian case, the employer and the employee, or if you prefer, the legal entity in regard to the individual taxpayer is privileged because generally plans are collective. There's a trend to the reduction of the individual plans, generally speaking only.
Renúncia da arrecadação.
The fiscal exemption, tax exemption there ends up reducing insurance prices paid by the employees and employers once the individual plans are not eligible for tax exemption. So that is also a strong difference that we found in this investigation. Since I'm always observing a Brazilian case, allow me again to say that here in Brazil that is possible. Generally, the high-income workers benefit more than those that have low income. Once again, we see the inequality subsidy aspect. It is allocated to those states that are intermediate or superior in income in the subset of those that are covered by the health insurance market.
Do ponto de vista da
From the point of view of making a policy explicit, the idea is to reduce the employer's costs. And if I understood Obamacare design well, they intend to use this mechanism to expand the coverage of that segment in the population that was outside of the system, so to speak. In other words, you're not poor enough to be covered by Medicaid and you're not old enough to be covered by Medicare. However, they don't have income to be in the market, either because they're too young or because they're immigrants or because they are underemployed. So the idea is to expand the coverage to that segment that was with no coverage, with no health insurance at all, nor private nor public, via subsidies of the health insurance market. In other words, is to widen the tax exemption mechanisms. So as I previously mentioned, considering that tax exemption, even though in the case of Australia, Canada, and the United States, this accounting, so to speak, is more transparent, something that we need to advance in South America. But anyway, once again, the exemption depends on the amount of expenditures of society, the employers in the North America, and the fiscal policy has no control over that. So we can regulate, we can assess the impact of such exemption over the system as a whole, the public and private ones, considering we can argue that those resources that are allocated in the private sector might be allocated in improvement of access to Medicare and Medicaid, which, by the way, was the proposal of Professor Marmer, which is a progressive expansion of Medicare, reducing the age for entering that market. So it's a trade. It's kind of a zero equation. So you take something out of the government, out of the state, to invest in the private sector, but then you diminish the possibility of access to the public sector, even though we can assess the need that other financing sources might have to be included in the health sector beyond the tax expenditures specifically. Next slide, please. At a first look, what are the challenges posed for governments in countries in South America? First of all, we should pay attention to the rationale of those subsidies, to the reasoning of them. Mainly in those countries where the public and private mix has been established already, whether it be from Social Security with private sector, whether it be with the universal model with the private sector. Secondly, we have to measure the amount and somehow incorporate that in the accounting, in the national accounts of the health sector. Those subsidies have to be measured and they have to be seen within this global approach. And the third challenge would be to assess the impact of such subsidies over equity and the equality and the efficiency of the system. As we saw, the subsidies focused to higher income people are, of course, contributing to inequality. And we can also say that if this tax exemption were designated to primary care, for example, or Medicaid, you would be able then to have a cheaper service with a bigger coverage and with better results in the health of those populations that are covered by Medicaid. So it's not only a problem of equality, but also efficiency. In other words, it's an inefficient allocation from the point of view that it produces worse results from the point of view of public health, if we compare them.
And particularly if the effects of these subsidies on the financing of health. See how perverse it is in the Brazilian case. Besides the subsidies, that is, what the state does not make in terms of money that theoretically could be applied on the public sector, the financing sources of health sector for drugs, for instance, are those that have less money. So it's a double punishment, so to speak. If this is not clear, we can repeat it. The fourth challenge, considering increasing presence of the indirect cost or tax exemption or subsidies, we should rethink the relationship between the state and the health area in this field of economy of the health issue. That's why I provoke the discussion based on a theoretical matrix. I would like that we could look at the empirical dimension of this problem, but at the same time reflect this empirical dimension and rethink the relationship between the state and the market vis-à-vis the needs of the health population in the South American area. I'm concluding. just to illustrate this discussion of subsidies in the discussion between universal system and universal coverage. As Dr. Joval and Mariana's yesterday, we have, in average, the expenditure of health, like 8% of the GDP, public expenditure. And most countries in Latin America and the Caribbean, it's not only us, Latin America plus Caribbean, the average is 3.8% health expenditures. The idea of universal coverage of health foresees an increase to 6% of public expenditures, but on the other hand, also the creation of a fund with subsidies to decrease the direct disbursement and reduce the catastrophic expenditures of the lower classes. I am saying that it seems that this is similar to one of the arrangements in the Colombian case. Well, based on this discussion we had on expenditures and health in these central countries, to explain these in the South American case, and quoting this discussion of subsidies as a mediation of the relationship between the state and the market, after the discussion between universal system against universal coverage, the final discussion I'd like to leave with you is that, considering that universality and equity are the objectives of the proposal of universal coverage of health, two objectives and two principles, so to speak. But they may not be guaranteed because this strategy presupposes this system where you buy and sell health services, so it's not clear the right point of view. So access to services may depend on the income, to a certain extent, the position in the working market, or the health condition of the populations. Because instead of increasing subsidies to the private sector, I ask, would it be more rational vis-à-vis the objectives, that is, universality and equity? To fulfill those objectives, wouldn't it be better to allocate those resources to the public sector? So I leave this question for us to think about it. And I would like to thank you all for your attention. For my presentation, I want just to introduce the issue so that we can share our experiences and we can highlight this debate in South America. Thank you very much.
Bien, muchas gracias por la...
Thank you very much for the presentation, for the didactics of your presentation, presenting these questions, these topics which are not, which people are not aware of, and the special language. And the special language of those working with health. And I believe that with that, we are comply with an objective of opening a black box, a Pandora's box, a theme for thinking. And I wish to open the session for question and answers, as you wish. I don't know. Yes, Fabricia. First, I'd like to congratulate for the excellent presentation. And without trying to agree or disagree with you, I would like to make a suggestion, perhaps. First, I must say that you said that one of the arguments for the fiscal incentive would be reduction of the waiting line and reduction of costs in the public sector. Well, we may say then that the impacts on primary care, public attention, would be very big if you remove this fiscal exemption. The coverage would increase a lot if we remove the beneficiaries of the private sector according to the logic of your presentation. This tax exemption encourage keeping those beneficiaries in the private sector. When we remove the incentive, then these people would go to the public sector, increasing the need of coverage, first of all. And the question is, do you think that this number that you said you have to measure would be enough to guarantee the assistance of those who came from the private system and then will be the users of the Universal Health System, the SUS? My suggestion would be to include in the issues to be, studied, measured, what would be the impact for the public system if this tax exemption didn't exist, if this incentive didn't exist? Don't you think that it would make the sector unfeasible? The microphone is not on. Yeah, the question is, anybody wants to ask anything or comment?
Is an excellent example of the advantages of looking at a subject. Is this too loud? Is that all right?
Yes, it's okay. It's fine.
What I would like to do is make some comments about tax expenditures to illustrate the advantages of thinking comparatively when you're exploring a subject like what's the nature of the tax expenditure, what's the social and economic meaning of it, and what would happen if you changed it. The first thing I would say is that these three examples, Australia, Canada, and Brazil, are not examples of the same kind of policy. It seems as if it is, because they share one feature. $1 of expenditure in this form has the property that it's worth more to a person whose tax rate is higher than somebody else's. Right? That is a property of any tax expenditure with a variation in the proportion of income that's taken by taxes. But beyond that, tax expenditures of the three kinds are really quite different. So, for example, in Australia, you have the equivalent of a bribe to expand private expenditures. Punishment, if you don't go into it, of a very serious kind. It's saying, we prefer expenditures to go through the private hospitals rather than the public hospitals, and we're going to make you pay a penalty if you don't do that. And the penalty is high enough to drag people into it. That's point one. That's radically different than the tax expenditure for costs of various items in medical care other than doctors and hospital care. In the Canadian case, the great bulk of expenditures are taking place within Medicare. So this is not taking Medicare expenditures and pushing them into the private sector. It's inducing people to spend something more than they would otherwise have spent on eyeglasses, on drugs, and so on. That's the second one. The third, which is the Brazilian example, is a case where there's double coverage. It's privileging private expenditure, but it's not doing so and keeping people in there. It's making it more possible than would otherwise be the case. So you have, I think, 3 different versions of what's called the same policy that are not, except in that one respect, the same policy. When you look at Germany, for example, and the punishments that take place if you go into the private sector and want to get out, that's a prudent public policy matter, because otherwise people would wait until the more expensive activities took place. I don't want to say anything more than the final point to emphasize is that by looking at 3 different examples, you see the different roles that an instrument that seems to be the same can play. But an instrument playing a different role is not the same instrument, is what I want to say.
Está aberto alguém, se alguém quiser fazer algum comentário, alguma
Anybody else?
pergunta.
Comments, questions? Anybody wishes to make a comment?
Sí.
Yes.
A mí me gustaría
I
colocar
would like to say that about the question involving equality, equity, and the question of the health as a right, because what we have to see is to see if health is a right and if the state must guarantee this right, or if the problem is that the individual is responsible for his own health care. In the case of Australia, I didn't know about it. It seems to be that the policy that the individual is in charge of his own health. So he has to buy a plan or an insurance in order to be safe during his old age, having an adequate coverage. I don't want to say if this is okay or not. The problem is how we see the state, if there is a right to health, and if there is not, the state is not responsible for granting the individual such a right. So the individual must pay for it, and he has to. I think that in the framework of our discussion of universal coverage, I think that these are the things that we have to stress, because the arrangements or the models of systems in each country that will offer in the area of health, they will depend on the social and political context in each case, because the health system is a political arrangement, a social and political arrangement. The societies, I want to cover this, I want to pay this for that. So it has to do with the proper history of each country. But I think that we cannot say, we cannot renounce, and we cannot discuss about the model to be adopted as universal coverage, or the discussion we will have has to have a clear focus on the rights, because health is a human right, and therefore the state must guarantee and grant these rights of health of people. Then, if this is also, I think when we have this type of discussion, I think this is going to take place tomorrow, the topic on the depth of the coverage and the quality of the coverages. These are very important themes also. Yesterday we said that the universal coverage can be an aspirin, or can be something more, something deeper for a few people in society. But anyway, what I wanted to say is that this question, which is the focus that we are going to adopt in terms of rights of a country,
I think that this will determine the question if this is a problem of the state, if this is a problem of the individual, and then in this regard, it is very clear that when it is a problem of the individual, the state will favor the growth of the private market because that is the manner to evade the problem. When it is a right, then we will have several or various forms of how the state will grant the rights, with a completely state system, a mixed system, or insurance system. That depends. I think this we can discuss, but it's important to point out the question of the rights to health. Anything else? Anybody else?
Well, first, I would like to try to answer what Dr. Fabricia mentioned in the following way. I agree there was a line missing. If we consider this dynamic, public and private, we should consider what are the impacts on the universal health system, so that this is a feasible policy, a policy with the responsibility. I'd like to add to the problem of the consequences of what Fabricia mentioned. First, well-being of families that today are covered by the health plans could be kept if this exemption existed, if we increase the regulatory mechanisms of the regulating agency. That is, the attempt to increase prices because there is no incentive on the other side would have the capacity or the increase of capacity of the regulating agency which is responsible for the activity. And I would go beyond. When we presented to you the idea that these resources should be allocated on primary care and secondary care especially, we are looking to the load of the disease in the Brazilian case because we have many chronic diseases. Once you put public money for primary care, which is fundamental for any universal health system, and even on secondary care, you are imagining that you have a type of intervention in the health system to avoid that people get ill in the population, during their life cycle. So this operation is not only a financial one. The objective is to strengthen attention model that would privilege preventive actions and promotion of health. Of course, that considering the population of Brazil, imagine that just changing indirect expenditures into direct is enough to cover the needs of the population through the public health system. But it is a problem, I agree, because if, from the well-being point of view of the families, if you remove the subsidy, they would have to spend more for their health. If we talk objectively, this expenditure is very unfair and imbalanced. It's a serious political problem. If you renounce, and I already answered the other question, and Dr. Helena, in the case of Brazil, that I'm not at easy to talk about the Australian case because the presence of Medicare is theoretically for all citizens in Australia. I would rather speak about Brazil. In Brazil, there is included in the Constitution that says that the health is a social right, and it depends on a set of policies. And at the same time, Professor Marmor, in Articles 199, in our Constitution, it says that it is a free initiative, health is a free initiative. So in our case, we have both conceptions as a responsibility of the individual and also as a right. They are all two included in our Constitution. So I agree with you. But what is supposed sometimes is not explained in the politics, in the policies in general. Going back to Fabricia's point. I don't want to seem partial. This is a discussion. It's a controversial issue in the Brazilian case. Are we going towards strengthening the public sector and the SUS when we improve quality and access to this universal health system? It will work as an attraction pole for private clients. So health as a social right. And once the public health sector serves the population, families would have more money to expend in max consumption. So we would improve the well-being of the population, not only through guaranteeing the social policies, but improving access of consumption goods like food, for instance, for society in general, housing,
and other goods. If we're going to follow that path, or if we're going to go to these dual parallel model that to a certain extent we are discussing now. And just to finalize, Professor Marmor said something really interesting. He said that the technique, it cannot be seen or analyzed in a disconnected way from its reality. In other words, only one technique can have different purposes and therefore unveils a technique that has a different nature. In other words, the technique has to be observed from the set of social and political organizations in which it is inserted. And I think that this approach can help us, as suggested by Professor Marmor. It helps us to escape certain tricks and pitfalls. In other words, the same policy can have a sense and a different functionality. We are different countries, and we are looking for, to a certain extent, we're trying to create an agenda, a common agenda. This Professor Marmor's suggestion might help us to build an agenda that is common without caring too much about certain differences, which would maybe make it impossible for us to have a common agenda. That's what I had to say.
Conclusion with Carlos. I think for this discussion, it would help if everybody around the table was perfectly clear about what in Canada is the policy towards supplementary coverage through private insurance of hospitals and doctors. And the answer to that, you may remember yesterday, but you may not, is that in Canada, there is a constitutional and statutory ban, refusal to permit private insurance for hospital coverage and physician coverage. Is that clear? It is illegal for anyone to buy supplementary insurance to contribute to the hospital bill or to the doctor's bill. Why is that important? It's because it illustrates the idea that the allocation of hospital care should not be mediated by the kind of insurance you have. By sharp contrast, in Australia, the government wants to run through, in a supplementary way, private hospital insurance because he doesn't want it to show up on the fiscal budget. Well, in Brazil, when you're thinking about tax expenditures, these two cases are sharp contrasts for you to think about. That's what I wanted to say.